One of the greatest challenges in oncology today is overcoming resistance to chemotherapy, a phenomenon that allows cancer cells to evade destruction even when exposed to cytotoxic drugs. Among the many adaptive strategies tumors deploy, autophagy has emerged as a critical survival mechanism, helping cancer cells withstand metabolic stress, DNA damage, and immune attack triggered by treatment. While autophagy in healthy cells plays a protective role by clearing damage and maintaining homeostasis, in the context of established tumors, it often becomes a double-edged sword. It shields malignant cells from therapeutic assault, allowing them not only to survive but sometimes to rebound more aggressively. This paradox has positioned autophagy as both a protective cellular mechanism and a therapeutic target, depending on context and timing. Chemotherapy, by design, induces stress, DNA breaks, oxidative overload, nutrient deprivation, and unfolded proteins flood the cellular environment. In response, many cancer cells ramp up autophagy, initiating a self-preservation process that recycles damaged organelles and proteins into usable components. This allows them to maintain ADP production, delay apoptosis, and ride out the most intense phases of drug-induced damage. Certain cancer types, such as pancreatic, lung, and glioblastoma, are particularly adept at exploiting autophagy for survival. In these contexts, autophagy functions as an internal shield, not only buffering against drug toxicity, but sometimes promoting dormancy, which allows cells to re-emerge later with renewed resistance. The implications are stark. Tumors with high basal autophagy levels, or those that rapidly activate autophagy in response to treatment, are often the most refractory to therapy. Recurrent cancers, those that return after an initial response, frequently display upregulated autophagy signatures, suggesting that the surviving cells were those best equipped to deploy this adaptive mechanism. In light of this, researchers have investigated whether disrupting autophagy could sensitize cancer cells to chemotherapy. The answer, increasingly, appears to be yes, but with important caveats. Autophagy inhibitors such as chloroquine and hydroxychloroquine, originally used as antimalarial drugs, have been repurposed in cancer trials to block lysosomal degradation, the final step of autophagy. When combined with chemotherapy, these inhibitors can enhance cell death by stripping cancer cells of their last resort survival tactic. Several early-phase clinical trials have shown promise, especially in cancers like glioblastoma, multiple myeloma, and non-small cell lung cancer. However, the effectiveness of this strategy depends heavily on tumor type, genetic background, and treatment timing. Autophagy inhibition is not universally beneficial and, if misapplied, can harm normal cells or trigger unintended compensatory pathways that undermine treatment. Moreover, autophagy's role in cancer is contextually complex. It can both suppress and support tumor growth. In early stages, autophagy may prevent cancer by removing damaged mitochondria and reducing inflammation. But in later stages, once a tumor is established, the same process aids in survival under stress. This duality means that therapeutic interventions must be carefully timed. In some cases, activating autophagy before or after chemotherapy could help clear dying cells more efficiently or reduce toxic side effects in healthy tissues. In others, suppressing autophagy during peak drug exposure may be essential to maximizing cancer cell kill. There is also growing interest in combining autophagy modulation with newer treatments like immunotherapy. Since autophagy intersects with antigen presentation and immune evasion, manipulating this process could potentially improve immune system recognition and destruction of tumor cells. But again, the risk of enhancing cancer cell survival remains if autophagy is boosted without careful targeting. Ultimately, targeting autophagy in chemotherapy-resistant cancers reflects a shift in strategy, moving beyond simply killing cancer cells to dismantling their survival infrastructure. Cancer does not just proliferate. It adapts, evolves, and resists. Autophagy is one of its most versatile tools. Turning this tool against it requires nuanced understanding, patient-specific approaches, and timing that aligns with each phase of therapy. If executed well, autophagy inhibition may not only restore chemosensitivity, but also prevent recurrence and improve long-term outcomes, transforming cancer treatment from a reactive war into a precisely guided dismantling of resistance itself.